Good morning. This is Emily Henderson, pharmacist with the Kentucky Hospital Association. Thank you for joining the Kentucky Statewide Opioid Stewardship Program's webinar, or Kentucky SOS, as we like to call it. Delighted to have Dr. Kristen Blankenbeckler this morning as a guest speaker. I have the honor of introducing her. Dr. Blankenbeckler received her doctorate in pharmacy from Mercer University in 2012. Since then, she has practiced in both retail and hospital pharmacy before joining the Kentucky Pharmacy Education and Research Foundation in 2020. As the Director of Clinical Outreach, her role is to provide education on the treatment of opioid use disorder, safe opioid prescribing and use, and harm reduction. Dr. Blankenbeckler grew up in and practiced for a time in Estill County, which ranked #1 in the state for overdose death rates per capita in 2017 and 2019. While working there, she was fortunate to be able to participate on a task force and with other efforts to combat the opioid epidemic in the area. It is her hope to effect great change for the future of Kentucky in her current role. Kentucky SOS welcomes Dr. Kristen Blankenbeckler.
Thank you, Emily. I appreciate that. I believe some of you were with us last month when we talked about ASAM's guidelines for the treatment of opioid use disorder. So today we're going to take it a few steps back and look at hopefully some prevention. And we're going to review the CDC's guideline for prescribing opioids for chronic pain. Very quickly, these were intended generally for primary care practice. They are again, for chronic pain. And these are a national guideline. So bear in mind, these don't specifically look at Kentucky state law or regulation. So keep that in mind as we go. But the thing that I do like about this guideline, it doesn't specifically talk about, it doesn't give specific drugs, doses, and recommendations for specific pain conditions, but it really walks us through kind of the thought process when we're prescribing opioids, which is a little different than most guidelines, but I think it's beneficial not only for chronic pain, but in any time we're prescribing opioids. So I don't have any disclosures for you. The objectives of this presentation are, of course, to discuss how we decide when we're going to initiate or continue opioids, the considerations for which opioid to select, how we're going to dose it, how long the patient's going to be on this medication, and how to follow up or decide when we may need to discontinue the medication. We're going to look at determining best practices for assessing risk and addressing harms with the use of opioids, and possible difficulties in implementing. Oh, and I think somehow I've got that on the timer, sorry. So discussing difficulties implementing the guidelines for prescribing opioids for chronic pain. So a little bit of background, as of the publication of this guideline, it was estimated that 20% of patients presenting to their primary care provider with non-cancer related pain received a prescription for opioids. So in 2012 alone, there were 259 million opioid prescriptions written. As the guidelines point out, this was enough for every single adult in the US to have their own bottle of opioids. And the greatest increases in opioid prescriptions have been from family practice, general practice, and internal medicine. So chronic pain has been defined different ways, but for the purpose of this guideline, it's defined as pain that lasts beyond the expected time of tissue healing or greater than 3 months. So in 2005, it was estimated that between 3 and 4% of the US population were receiving long-term opioid therapy. And this is concerning, of course, because of the risks associated with that opioid therapy. Between 1999 and 2014, there were 165,000 opioid-related deaths in the US. In 2011 alone, there were more than 420,000 ED visits related to abuse or misuse of narcotic pain relievers. And I believe we've all heard the recent news that there were 100,000 deaths in the US last year. I think that was from April of 2020 to April of 2021. So that alone was a 28.5% increase from the previous year. So the CDC Guideline for Prescribing Opioids for Chronic Pain aims to improve prescribing practices by improving clinician knowledge and influencing prescribing practices, which thereby will improve safety and reduce the risk of adverse outcomes associated with opioid use. It's important to remember that the recommendations are guidelines, and therefore they're not meant to be hard and fast rules. While the recommendations should be implemented in many or most cases, there will be cases where clinical judgment will lead you to act in a different manner. And I'll discuss this along the way, but it's important to remember, especially when citing these guidelines, as reasoning for enacting policies or law. So I won't spend a lot of time on the methods for determining recommendations, and I'll refer you to the guidelines for that information if you're interested. But I've included the evidence types and recommendation categories so you can refer to them throughout the presentation or in the future if you want to look back at the slide set. So this slide is rather wordy, but I included it so that, again, as we go through, you can refer back and you'll have the verbatim recommendations. I kind of pare them down a little bit as we go. So we'll go over each one individually, starting with the recommendations for determining when to initiate or continue opioids for chronic pain. So recommendation 1 indicates that non-pharmacologic or non-opioid pharmacologic interventions as treatment of choice for chronic pain. Keep in mind this recommendation is category A, meaning all patients should receive this course of action, but if an opioid is considered, it should only be used if the anticipated benefits to pain and function outweigh the anticipated risks, and it should be combined with adjuvant treatments. Also bear in mind that opioids have been shown to reduce pain in the short term, but their sustained effects long-term are questionable. So non-pharmacologic therapies include, of course, physical therapy, weight loss, exercise therapy, psychological therapies such as cognitive behavioral therapy or CBT. Appropriate non-opioid pharmacologic therapy may vary depending on the type of pain. So examples of this include, acetaminophen or NSAIDs for arthritis and low back pain, or the use of pregabalin, gabapentin, or certain antidepressants for neuropathic pain. These medications also come with risks, especially in older patients, pregnant patients, patients with certain comorbidities. So risks and side effects of the class or individual agents have to be considered. Multimodal treatment or treatment with more than one therapy is recommended, as it's been shown to reduce long-term pain and disability compared to usual care and physical treatments. It's also opioid sparing, meaning it allows you to use less opioid, which helps to decrease risk and side effects of opioid use. So this is an area too where dispensing pharmacists can be particularly impactful by helping chronic pain patients determine which over-the-counter products can help to safely augment their prescription therapy. These guidelines were published in 2016. In the time since their publication and subsequent implementation, different concerns and difficulties have been brought to light. Many of them discussed in an article by Cronky and colleagues were published in the journal Pain Medicine in 2019. So as they point out, and as many of you may have experienced personally, non-pharmacologic therapies may not be reimbursable by insurance or may have prohibitively expensive copays if they are. For instance, if a patient has a copay for physical therapy, they may have to pay that copay 3 times weekly for 3 or 4 months. This is difficult for many patients. So it isn't uncommon for a 1-month supply of opioids to be drastically less expensive than a month of physical therapy copays. So my experience growing up in a rural area tells me that the use of non-pharmacologic treatments is often inhibited by transportation difficulties, as physical therapists, occupational therapists, massage therapists, or psychologists may not be available in close proximity. One positive to come out of the pandemic, of course, is the increase in telehealth services. It's pushed practitioners, lawmakers, and payers to embrace technology, but some of these methods are still not available via telehealth. So for recommendation number 2, we want to have an open, clear conversation with your patients about goals for treatment prior to initiation and set realistic expectations. So for example, opioids will not likely take a patient's pain from a 9 out of 10 to a 0 out of 10. So knowing this up front can help make realistic results more acceptable to the patient and speak not only in terms of pain, but also function. So for example, maybe their goal is to be able to shoot basketball with their grandson or walk around the block without assistance. Do keep in mind there may be times that functional goals aren't appropriate, such as with spinal cord trauma. But also bear in mind there's insufficient evidence to suggest that long-term opioid therapy provides continued clinically significant pain relief. And this is something that should be communicated to the patient when discussing therapy. So set clear expectations regarding your practice as well. And this includes how the medication will be prescribed, like how often the patient will need to be seen in office and monitored via PDMP or random pill counts. And monitoring can be done both by the office and the dispensing pharmacy as is appropriate. It's also important to establish reasons for which the medication may be discontinued or tapered. So these could include inefficacy or goals not being met, an inappropriate drug screen, or if the patient experiences significant adverse effects. So we want to establish ways to evaluate the effectiveness. We can use clinical rating scales such as the PEG, can help with that. And a comparison of the initial score to the score after treatment can help to be a little more objective in determining clinical significance of efficacy. Generally, we consider at least a 30% improvement in pain and function to be clinically significant. If the patient doesn't experience meaningful improvements in pain and function, then we want to consider working with the patient to taper and discontinue.
That way, and I can't.
So this is the PEG tool. It's the Pain Enjoyment of Life and General Activity Scale. It's a simple tool that can be completed in just a couple of minutes, administered by staff, or the patient can complete it on their own. You would want to administer this prior to the initiation of a new medication or a dosage increase. And then at the established follow-up, you'll be able to more objectively determine the efficacy of treatment, as pain is an inherently subjective experience. I do say that this, using this gives you a little more objectivity. Again, you have to bear in mind their ratings are subjective. So we always have to kind of take this with a grain of salt and in context. So discussion and education should be ongoing, starting prior to the initiation of opioid therapy. Thorough education allows you and the patient to make informed decisions that consider the patient's values and preferences and allows you the opportunity to correct any misperceptions. So some patients are still under the mistaken impression that you can't become addicted if you are in real pain or if you follow the doctor's instructions. Education should include, again, realistic expectation of benefits. So to reiterate, what I said earlier, it's important that they understand opioids aren't going to take their pain from a 9 out of 10 to a 2 out of 10, but it may allow them to reach certain goals like participating in yoga classes, being able to hold their grandchild without assistance. So those are the things we want to focus on. Improved function should be the primary goal, and that can occur even in the setting of continued pain. So education should also include common and serious harms, which of course can range from constipation, drowsiness, dry mouth, nausea and vomiting, all the way to respiratory depression and death. Finally, patients need to be educated on their responsibilities of both patient and provider to mitigate risks. So, the prescriber's role would include reviewing PDMP, prescribing the lowest effective dose along with adjuvant treatments, conducting the urine drug screens, and prescribing naloxone. The patient's role is to include reporting side effects in a timely manner, locking up their medications, taking the medication only as prescribed. And patients should always be included in the decision to start opioids. If they aren't comfortable taking them and you prescribe anyway, just in case, there may well be a full bottle of opioids sitting in the patient's medicine cabinet unused and available for diversion. So just a quick question to kind of touch base and review. During his last visit, it was decided to initiate opioids for treatment of MB's low back pain after NSAIDs and physical therapy had been insufficient to improve his pain. So at that visit, his PEG score was 8.33, and after 4 weeks of opioid therapy, the score is now 5.67. Is this clinically significant improvement? Let me go just a quick second, and bear in mind, the answer may not be cut and dry or black and white. So for this, I would say yes, that is clinically significant. There's an almost 32% improvement in their pain rating score, which, as we said before, greater than 30% is generally considered clinically significant. So prior to initiation of opioids, a patient with chronic knee pain agreed that a goal of pain improvement from 8 out of 10 to 5 out of 10 was acceptable. And for functional goals, she wanted to be able to sleep for longer periods at night, and she wanted to be able to go on daily walks like she used to. At her follow-up 1 month later, she states her pain is now 6 out of 10, but she has been able to sleep for 6 hours at a time instead of waking up every 3 to 4 hours from the pain. And she's been able to walk a mile, albeit slowly, daily. She experiences some additional pain after she walks, but she's very pleased that she's capable. Is her improvement significant enough to continue with a possible adjustment, or would you taper and discontinue? I would consider this a therapeutic success. So while she didn't have a 30% improvement on her numeric rating scale, she got close. But you also have to consider that while the math to determine percentage improvement is objective, again, the numeric rating itself is subjective, and the results should be considered in that context. But more importantly, she's meeting her functional goals. So it's possible she didn't meet the numeric rating scale because her daily walks are adding to the pain and inflammation. This would be a good opportunity to discuss adjusting her therapy. And while you could consider slightly increasing her opioid dose, either increasing the strength or giving her an extra dose to take on days she walks, you also want to make sure that adjuvant treatments are also optimized. So she already on an NSAID. Something like adding ibuprofen prior to her walk may help decrease pain and inflammation. You could recommend she prop her knee up in ice or some other possibilities to help with that pain. So the second section deals more with specifics of therapy, such as opioid selection, dosing, duration, follow-up, and discontinuation. Again, this is really wordy, but just to kind of show that it's broken into the 3 categories again, and we'll go through each one individually. Recommendation 4, opioids should be initiated with immediate release formulations, as the extended release and long-acting formulations confer a higher risk for overdose. The time-scheduled continuous use of the ER and LA opioids have not been proven to be more effective than the intermittent immediate release, nor do they decrease the risk of misuse or addiction to a large degree. The mechanisms that they use for to prevent abuse don't prevent abuse via the oral route, which is the most common route of opioid abuse. Methadone specifically has been associated with a disproportionately high number of overdose deaths based on the frequency of prescriptions because of the complicated pharmacokinetic and pharmacodynamic profile. It's got a long and variable half-life and affects the QT interval. Transdermal fentanyls pharmacodynamics are also complex. So serum concentrations increase during the first part of the dosing interval, and absorption can vary based on different factors. And as such, these should be reserved for instances where alternatives aren't tolerated, aren't effective, or are inadequate. And they shouldn't be used as needed. They're generally only appropriate in opioid tolerant patients. And that's technically defined in package inserts, but generally around 60 milligrams of oral morphine or 30 milligrams of oral oxycodone daily for at least a week is what we call opioid tolerant. There's insufficient evidence to determine safety of using the immediate release formulation in combination with the ER and LA formulations outside of cancer, pain, palliative care, and end-of-life care. So in changing from IR to ER formulations, we always want to consult package labeling for conversion and reduce the total daily dose to allow for incomplete cross-tolerance. So the 5th recommendation is basically start low and go slow, periodically reevaluating risk and benefits. Relative benefits of high-dose opioids have not been established, but the risk has. Serious harms include motor vehicle injury, OUD or opioid use disorder, and overdose death. There's a direct relationship between dose and risk. There's no specific dosing threshold that confers safety, but most experts agree that doses greater than 50 MME a day increase the risk without sufficient benefit in pain reduction or functional improvement. Doses from 50 up to 100 MME a day increased risk for overdose by around 2 to 4.6 times compared to doses of 1 to 20 MME per day or less. Doses greater than 100 MME per day are associated with an increased risk of overdose 2 to almost 9 times. So we want to reevaluate risk and benefit when increasing dosages to 50 MME per day or greater, or milligram morphine equivalents. This is also a good time to increase the frequency of follow-up visits. An naloxone prescription would be appropriate as well. Pharmacists can make the recommendation to their patients at this dosing and dispense the medication via the statewide physician protocol. And when titrating, doses should be increased by the smallest practical amount. The recommendation is to wait at least five half-lives or a week for methadone before increasing the dose. And doses of 90 MME per day or greater should be carefully justified based on diagnosis, risk versus benefit, and optimization of adjuvant therapies. It would also be appropriate to consider referral to pain management for patients requiring this dosage, either to manage such high dosing or to help determine effective non-opioid therapies that would allow for a decrease of the opioid dosing. If the pain and function aren't improved, consider tapering. Patients may be anxious, but this should preferably be done in agreement with the patients. Patients on this dose will likely require a slow taper and or pause to prevent withdrawal. Be alert to anxiety, depression, signs of OUD, and manage those accordingly. Cronky and colleagues that we discussed earlier cautioned against using this recommendation to set hard limits on dosing. The guideline recommended individual dose determination, and there are risks associated with tapering patients against their will or too quickly, even when they are willing. Withdrawal, increased anxiety, increased pain, or decreased treatment efficacy. It could even lead them to procure medication through illicit means. So this is not to say that a patient must agree to the taper. If it's clear that opioid therapy is endangering the patient, or that they have been or will likely be harmed by the treatment, then obviously it's the responsibility of the provider to mitigate risk. This slide, I don't really have anything to go over with you. It's just a table of the morphine milligram equivalencies that you can use for conversion. The sixth recommendation points out that long-term opioid therapy generally starts with acute treatment. For acute treatment, the patient should receive the lowest effective dose of an immediate release formulation in a quantity no greater than what they're expected to need for the duration of pain severe enough to require opioids. So risk maintains a direct relationship with the amount of early exposure to opioids. Different guidelines vary in recommendations for acute pain prescriptions, but generally recommend less than 3 days, less than or equal to 7 days, or less than 2 weeks. The duration of acute opioid therapy is important because physical dependence can occur after just a few days of exposure. So prescriptions for greater than just a few days may increase risk of adverse effects, physical dependence, and unused medication being stolen or diverted while failing to confer additional benefit. So Cronky and colleagues again warned against using this guideline or these thresholds as firm limitations, and reiterate the need to heed their advice regarding the individualization of treatment. Many states and third-party payers have enacted laws and policies to limit prescribing or coverage of prescriptions. So in Kentucky, for instance, in House Bill 333, they did limit the prescribing of pain medications for acute needs to 3 days, but they did have the forethought to build in numerous exceptions, including the prescriber's professional judgment, providing the reasoning is adequately documented. They also included verbiage that allows pharmacists to assume that the reasoning for extended therapy is valid and adequately documented if they receive an acute pain medication that meets all the other thresholds for legitimacy. In regard to payers, Medicare is an example of a third-party payer who's limited the day supply that a patient can receive for an acute pain medication prescription without a coverage determination, with Part D allowing, I think, only 7 days if a patient is considered opioid naive. So recommendation 7 suggests generally evaluating therapy within 1 to 4 weeks of starting opioid therapy or of dose escalation, and reevaluating a minimum of every 3 months thereafter. The risk of overdose is greatest in the first 3 to 7 days after initiation or dose increase. Of note, it is recommended to follow up in 3 days for methadone and 7 days for other extended release or long-acting formulations or doses greater than or equal to the 50 MME per day. The evaluation should include an assessment of pain control, function, and quality of life. This can be accomplished, again, using tools such as the PEG tool we mentioned earlier, or by simply asking patients about progress toward functional goals that have meaning for them. Ask about side effects, and specifically effects that may indicate a greater risk for overdose, like sedation or slurred speech, or opioid use disorder, like cravings, taking more than prescribed despite knowing the risks. Reevaluate the patient's desire to continue therapy. Are they content that they're adequately meeting treatment goals? Are they experiencing sustained pain relief, continued improvement in function, any signs of adverse effects or opioid use disorder? And keep in mind, if patients aren't experiencing pain relief at 1 month, it's not likely they'll experience pain relief at 6 months. So if it's determined that discontinuation or tapering is prudent, then optimize the other therapies or consider consulting pain management. Patients with greater risk of opioid use disorder should be reassessed more frequently. And this could include patients with a history of depression or mental health conditions, patients with a history of other substance use disorders or OUD, or again, a dose of 50 MME per day, or a concurrent central nervous system depressant. So to round out that section, just a couple of quick review questions. So RK is a 56-year-old female with chronic shoulder pain following a work-related injury. She's taken ibuprofen 400 milligrams every 6 hours as needed for the last 3 months, and has also tried physical therapy with some relief. Her physical therapy copay was more than she could afford to continue beyond the initial month, but she tries to do some of the exercises on her own at home when she can. She reports continued pain 7 out of 10 and decreased function. And you've discussed the risks and benefits of opioid therapy over several visits. And after initially declining, she feels that she's given the other therapies an adequate trial and feels that an opioid is the next best step. Which of the following is the best starting regimen for opioid therapy? So we've got a fentanyl transdermal patch, 12 micrograms an hour, apply 1 patch topically every 72 hours. A hydrocodone with acetaminophen, the 5/325, 1 every 6 hours is needed. Oxycodone ER, 10 milligrams every 12 hours scheduled, or methadone 2.5 milligrams every 8 to 12 hours. For this one, the hydrocodone would be a reasonable choice. It's an immediate release formulation. Quantity should be written, the quantity written should be individualized based on how consistent the pain is. You know, does she need around the clock dosing, or will this is as needed dosing sufficient? That'd be the best way to start in general anyway. Of course, the fentanyl patch would be incorrect, as we discussed. It's recommended we start with immediate release formulations for opioid naive patients. So she's not opioid tolerant, and this wouldn't be used. The oxycodone, again, immediate release formulations are what are recommended. And then the methadone specifically, as we mentioned, has been associated with a disproportionate share of overdose deaths compared to the number of prescriptions written. Again, the pharmacokinetics and pharmacodynamic profile make it a poor choice for opioid initiation, and should definitely only be used by providers who are really familiar with it. So you initiate RK on a regimen of the hydrocodone acetaminophen 5/325 every 4 to 6 hours as needed. The patient agrees to continue her regimen of ibuprofen as needed, as she has seen some improvement and understands it may help decrease the need for opioids. And she expresses her intention to only use them sparingly. So what's an appropriate follow-up interval? I've got, A is 1 week, B is 2 weeks, C is 4 weeks, and D is 12 weeks. And this one is kind of a trick question. Without a little more information, in all honesty, A, B, and C would be reasonable answers. So you may want to schedule a 1 or 2 week follow-up if the patient's had a condition that put them at a greater risk for adverse effects, such as if she has sleep apnea or reports previous adverse events using opioids for acute pain. You may want to follow up in shorter intervals if they've had substance use disorder in the past, or if she's taking medications that put her at risk, like benzodiazepines. If there aren't circumstances indicating a need for increased monitoring, a 4-week follow-up is reasonable. This interval is used often as most chronic opioid prescriptions are written in monthly supplies, and patients are often scheduled monthly for that purpose. It also gives the patient an adequate trial of the regimen and allows them to adjust to some of the common side effects that improve with time. So the patient should be educated by both prescriber and dispensing pharmacist regarding side effects to monitor for, as well as the need to contact the office or the pharmacy with any concerns. And once the patient is established on a consistent dose of opioids, then a follow-up interval could be increased to every 12 weeks. So the final section of recommendations is committed to assessing risk and addressing the harms of opioid use. So recommendation 8 suggests to evaluate risk factors for opioid-related harms, both before opioid initiation and periodically for the duration of opioid use. These risk factors include a history of overdose or substance use disorder, higher opioid doses greater than or equal to the 50 mme per day, or the concurrent use of benzodiazepines. Providers are responsible for putting measures in place to mitigate risks. And these measures may include offering naloxone or referring the patient to pain management. Specific populations warranting special consideration during evaluation include patients with sleep disordered breathing, pregnant women, patients with renal or hepatic insufficiency, patients older than 65 years old, those with mental health disorders, known substance use disorder or history of prior non-fatal overdose. Those with sleep disordered breathing are at an increased risk for respiratory depression and should be carefully monitored and titrated. And opioids should be avoided in patients with moderate to severe disease. Risks during pregnancy include possible stillbirth, poor fetal growth, preterm delivery, birth defects, and neonatal opioid withdrawal syndrome. Pregnant patients with substance use disorder should be offered medication-assisted therapy with buprenorphine or methadone. Patients with hepatic or renal insufficiency may metabolize opioids more slowly, warranting a slow titration and frequent monitoring. And patients over 65 tend to have decreased renal function and also warrant slow titration and frequent monitoring. They may also be at a greater risk from non-opioid pharmacologic therapies and may suffer more cognitive impairment, which increases their risk from side effects as well as risk for taking the medication inappropriately. So patients with mental health conditions are more likely to be on benzodiazepines concurrently, and treatment for depression should be optimized prior to the initiation of opioids, and they should not be started during an acute psychiatric episode. Risk stratification tools should be used to screen for substance use disorder. This doesn't preclude these patients from opioid therapy, but there should be careful justification and sincere efforts to implement risk mitigation strategies. Referral to pain management and substance use disorder treatment would be prudent. And if a patient experiences a non-fatal overdose, strongly consider tapering and discontinuing the opioids if possible. If it's necessary to continue, naloxone should be offered and monitoring increased. So prescription drug monitoring program, or PDMP data, should be reviewed to discern whether the patient is receiving controlled substances such as benzodiazepines or other opioids from other providers that may put the patient at increased risk. This data should be reviewed prior to initiation and periodically in frequencies ranging from each visit, which an opioid is prescribed, to every 3 months. This can be done by both prescriber and pharmacist, not only at the recommended intervals, but also whenever the practitioner feels it's appropriate. Keep in mind when reviewing this data, there is potential for error. Reporting has improved in regard to frequency of reporting, meaning you can generally see the information as recent as the previous day. However, you must also consider your geographic location. Are you near a state border? Is it possible the patients fill prescriptions across state lines? If so, does your PDMP share information with that state? If there is unexpected information, have that conversation with the patient and keep an open mind. It is possible the prescriptions are reported to the wrong patient's record, either because of an error on the part of the PDMP or because an error on part of the pharmacy. Records may list wrong days of supply if entered incorrectly at the pharmacy. These can be clarified by contacting the submitting pharmacy or prescribing provider if need be. And of course, those are rare instances. I just want to, put out some examples that I may have seen in the past for you to keep in mind when reviewing that data. So urine drug testing should be performed prior to the initiation of opioids and at least annually during opioid therapy. Testing should be used to look for both the controlled medications prescribed as well as other prescription and illicit drugs. They do not provide information about what amounts or doses of a medication they've taken. Urine drug tests should be used regularly as a means of destigmatizing their use, but their additional random use may also be necessary when deemed appropriate. Some clinics collect urine for screening at every visit, but only perform the actual screening randomly. And this can be effective while also saving time and money. The use of drug screen should be discussed when prescribers explain the management of care when opioids are initiated for chronic pain. And if the patient's at increased risk for OUD or has a history of a substance use disorder, it'd be reasonable to do urine drug screen more frequently as a deterrent and as a means to recognize problems quickly. If the prescribed medications are absent in a test and you determine that the patient is diverting the medication, it's reasonable to stop the medication without tapering it. If the test contains not only the prescribed medication, but also other unprescribed medications or illicit substances, the patient may need to be tapered off the medication for it to be safely discontinued. While it's beyond the scope of this training, I would highly recommend educating yourself regarding urine drug screens and how to accurately interpret the results and learn what metabolites should be anticipated and ways that screenings can be altered. So when possible, opioids should not be prescribed concurrently with benzodiazepines. Both medications cause central nervous system depression, leading to decreased respiratory drive. This increases the risk of fatal overdose. One study found nearly 4 times the risk of overdose associated with the combination than with opioids alone. There may be times the combination is necessary, but patients should be monitored frequently and dose titrations should occur slowly. There's a greater risk of benzodiazepine withdrawal than opioid withdrawal, and tapering opioids can cause anxiety. So if possible, it's recommended to taper and withdraw opioids first. The abrupt discontinuation of benzodiazepines, of course, can lead to rebound anxiety, hallucinations, seizures, delirium tremens, and even death. Other classes such as muscle relaxants or hypnotics may have similar effect and should also be similarly monitored. So opioid use disorder is defined in the DSM-5 as a problematic pattern of opioid use leading to clinically significant impairment or distress. It's manifested by at least 2 defined criteria occurring within a year. And per the guidelines, a review of clinical evidence places frequency of opioid dependence in the primary care setting among patients with chronic pain on opioid therapy as anywhere from 3 to 26%. You may determine that your patient is at risk for OUD based on patient behavior, standardized screening, review of PDMP or urine drug screen results, or other clues. Discuss your concern with your patient in a manner that welcomes their disclosure, which can lead to an opportunity to share resources with them. And for pharmacists, depending on your relationship with the patient, it may be prudent to discuss your concerns with the provider to allow them to investigate further, utilizing random pill counts, urine drug screen, PDMP, etc. Opioid agonists or partial agonist treatment with methadone therapy or buprenorphine has been shown to be more effective in preventing relapse among patients with opioid use disorder. Behavioral therapies used in combination are suggested to reduce opioid misuse and increase retention in maintenance therapy. Oral and long-acting naltrexone can also be used in non-pregnant adults and in patients who are highly motivated. Bear in mind this treatment has an opioid-free requirement that can be difficult for some patients in active addiction to achieve. This recommendation may be hard to follow in regard to actually arranging or ensuring that your offer isn't in vain, as the availability of these treatments is highly limited in comparison to need, both geographically and in relation to cost. Although many third-party payers are now covering at least one treatment option, I think Kentucky or Medicaid now covers pretty much every option, so that's wonderful. It's also dependent upon the patient's willingness to participate. If you're prescribing or dispensing opioids, I recommend you compile a list of available MAT prescribers, counselors, treatment facilities in the area that you can provide to patients when it's needed. And if you're prescribing opioids in an area that doesn't have an MAT provider, I recommend considering obtaining your X waiver. Simply dismissing a patient from your practice for substance use disorder can have negative effects on the patient's health and could constitute patient abandonment. That's actually written in the guidelines. So if you are a pharmacist dispensing opioids in an area with no MAT providers, I suggest speaking to providers with whom you have a strong relationship about getting their waiver. And then also for pharmacists, consider providing long-acting naltrexone injections, which can be done via a board-authorized protocol, which I've provided a link to here. So just some follow-up questions for this. Which of the following are considered an increased risk factor for opioid overdose? We've got a history of alcohol abuse, anxiety, managed non-pharmacologically, history of MS Contin 30 milligrams POBID, or by mouth twice daily, and history of non-fatal overdose. And so all of those with the exception of the anxiety managed non-pharmacologically. The dose of MS Contin, of course, because of the MME per day is the risk factor. Now, if the anxiety were being managed with a benzodiazepine, this would be an increased risk factor for opioid overdose. So after treating EP for chronic pain for 2 years following a serious car accident, he begins exhibiting signs of opioid use disorder. You review the PDMP, conduct a random urine drug screen, and have the patient bring his bottle in for a random pill count. Based on the evidence and your discussion with the patient, you determine that he does not meet the DSM-5 criteria for opioid use disorder, but he is exhibiting signs of misuse. So which of the following actions are appropriate based on this knowledge? Stopping the patient's opioid prescription immediately, discussing your concern with the patient, and obtaining consent to taper the opioid in order to discontinue therapy, offering a referral to the provider of MAT, or offering a referral to pain management. So I selected B and D. As far as A, stopping the patient's prescription immediately, this one I would not have selected because of the risk of withdrawal, which would be detrimental to the patient's health. And could also lead the patient to seek treatment from illicit sources. I chose B because this answer, discussing the concern with the patient and getting their consent to taper is a good starting point. It's best to obtain consent and cooperation to taper. It's not required, again, that they agree. Like I said, it is a little better if you have their buy-in, so we don't risk them obtaining the medication elsewhere. The referral for treatment of MAT, they didn't technically meet the criteria for opioid use disorder, so it isn't technically recommended. Again, this is something you could use your judgment. The referral to pain management, this again may not be necessary, but it may be the best option for the patient. If they've tried and failed non-opioid treatments and still require pain management, but they're at risk for use disorder, and you may feel this is above your expertise. If they're willing to try other non-opioid therapies, but you think it's out of your scope of practice, then it may be time to refer them on to pain management for a little more help. And then the final is just, remember, always use your clinical judgment. Again, these are a guideline, these are best practices, but the guideline is very clear that each patient should be treated in a manner that's appropriate for them, not based on just arbitrary numbers that have been given in law or made up by insurance companies and so forth. So. And if anybody has any questions at this point, I'd be happy to take them.
Thank you so much, Dr. Blankenbeckler. If you have questions at this time, feel free to unmute your phone and ask them over the open line, or feel free to type them in the chat box. Also, Kentucky SOS is delighted once again to provide continuing education for medicine, pharmacy, and nursing. And we will put the portal up on the screen for you. Reminder that you must wait until after 12 noon today to submit the evaluation to receive continuing education. The portal does close on January 17th at 11:59 Eastern Time. So make sure you complete your evaluation using this access code before then to get continuing education, again, for medicine, pharmacy, and nursing. I will also send out these portal instructions to all the attendees today. At this time, again, if you have any questions, feel free to ask them over the phone or type them in the chat box. Dr. Kristen Blankenbeckler has been so gracious to share her email with us, and that's being typed in the chat box now. If you maybe want to contact her in the future, by all means, feel free to do that. Any questions at this time for Dr. Blankenbeckler? We appreciate everyone being on the line today. I know this is a very busy time, not only in the hospitals, but across our state, and Kentucky SOS always appreciates your participation. We'll put the portal instructions back up there one last time to make sure you do get the access code for that. Again, I will email that out to all the participants. But if you can't think of any questions off the top of your head, we'll go ahead and end today's webinar. But first, I want you to save the date for Kentucky SOS January webinar, which is January 18th. Dr. Alex Ellswick, who is a member of Kentucky SOS Advisory Committee, will be presenting on This Is Your Brain on Recovery. That webinar will be 11 a.m. to noon Eastern Time, and more information will come out closer to date, but save the date for that. Again, this webinar and past webinars are listed on the Kentucky SOS website. Feel free to refer to those at any time and share the website with your colleagues and your family members and neighbors. It is a public website. There's a lot of resources on there. You can go to www.kentuckysos.com, and that's a great resource for you and your colleagues also, and lots of education on there. One last time, are there any questions for Dr. Kristen Blankenbeckler at this time? Well, if not, thank you so much, Dr. Blankenbeckler, for your education last month and this month. And we look forward to working with you and collaborating more from the Kentucky SOS team, which consists of Claire Arendt, Melanie Mock, myself, Emily Henderson, and our intern who has just completed her internship, Kayla Rowe. We wish you a healthy and safe holiday season, and we look forward to seeing you again in January. Have a great day. Thank you.